Good morning. My name is Nida Zubair. I'm a second year internal medicine resident at North Alabama Medical Center, and the topic of my case report is drug-induced euglycemic diabetic ketoacidosis in a patient with systemic sarcoidosis. So, in the introduction, I will talk about sarcoidosis is a systemic disorder with a wide range of manifestations. It's a non-infectious granulomatous disease affecting multiple systems and including CNS, cutaneous, and ocular involvement, and with pulmonary involvement being the most common ones. So for the treatment of sarcoidosis, steroids are the mainstay of therapy. And we present a case of euglycemic DKA, which is diabetic ketoacidosis, in a patient with sarcoidosis who was treated with systemic steroids. So, a 78-year-old female with a past medical history of hypertension. She had non-insulin dependent type 2 diabetes mellitus and sarcoidosis with pulmonary and bilateral ocular involvement, presented with complaints of vague abdominal pain, which was accompanied by nausea and vomiting. Her medications, which she was taking at home, include SGL2 inhibitors, empagliflozin and metformin and sitagliptin for her diabetes. So the patient was recently initiated on prednisone. It was 20 milligrams twice daily for the treatment of pulmonary and systemic sarcoidosis flare, which she was diagnosed with as an outpatient. And notably, she also had a very poor glycemic control since the initiation of steroids. So on admission, vital signs were stable. Her physical examination, including the abdominal examination, was unremarkable. Investigations included sodium, which was around 130, potassium was 4.4, bicarb was 13, and NGAP was 22, and creatinine of 1.1, and elevated beta hydroxybutyrate of 9.2. So workup for high NGAP metabolic acidosis revealed that she also had elevated beta hydroxybutyrate and urinary ketones of almost 80 milligram per deciliter, and with a lactate of 2.1. So then further imaging revealed a CT of the chest, like soft tissue and mediastinum with bilateral perihilar regions and calcifications that were consistent with the diagnosis and the flare-up of sarcoidosis and worsening of that. And there was also suspicion of underlying pneumonia. So our final diagnosis was drug-induced euglycemic diabetic ketoacidosis. So now I will talk about management and discussion. So a diagnosis of euglycemic DKA was made, and she was admitted to the critical care unit, and treatment per DKA protocol was initiated with keeping that in mind. Because it was euglycemic DKA, the D5-dextrose was initiated right from the start, and she was also started on intravenous antibiotics for suspected pneumonia. So her steroids were discontinued. However, in 2 days, she started developing worsening of her vision and dry eyes, and worsening of her pulmonary as well as ocular sarcoidosis. So we had to restart her on IV prednisolone, and with keeping a close eye on glycemic control. So we decided that usually the dose for sarcoidosis flare-up steroid is between 0.3 per kg to 0.6. And our goal was to start on the lowest possible dose that she can tolerate. To our knowledge, this was the first case to be reported as like DKA euglycemic in the context of sarcoidosis, as she was taking systemic steroids as well. Although we we did notice like the role of SGLT2 inhibitors like empagliflozin could have compounded the overall situation and contributed to the development of DKA. But the temporal association between the onset of the euglycemic DKA with the initiation of steroid therapy, it could not be dismissed. So we concluded that our patient basically highlights therapeutic dilemma encountered during the management of systemic sarcoidosis when patients develop an adverse event related to steroids. Ideally, short-term insulin therapy with discontinuation of the offending agent would be the cornerstone of management. However, this strategy added another layer of clinical complexity by worsening the sarcoidosis flare. So the patient was eventually discharged and on insulin, and with the lowest possible dose, it's usually between 0.3 per kg, 0.6. So we decided on 0.3 per kg with outpatient follow-up and with the addition of a second agent for sarcoidosis. Thank you.
Thank you. We'll open the floor to see if anyone has any questions in regards to the case.
Sorry, I couldn't hear you.
Can you hear me now?
Yes, I can.
I was saying we'll open up the floor to see if anyone has any questions. But since it looks like no one has an urgent question, then I'll ask a question.
Mhm.
My question is, how soon after the DK episode was steroids resolved? I think I may have missed that. Or steroids restarted.
Right. So it was right the day after, like when her anion gap closed, she was initiated on oral feedings. Her steroids were started the next day with the lowest possible dose, and she fairly tolerated it well.
And she was on no other medications that would potentially like start or incite euglycemic DK, such as like SGLT2s or nothing like that.
Right. So on the outpatient, because there was consideration that it could have overall also compounded, but before that, before she even got admitted, she's been taking like SGLT inhibitors for a few years. But then because of this concern, the steroids exacerbated, so we did not discharge her on SGLT inhibitors. Right.
Gotcha. Okay. Thank you.
Thank you.